So I'll be focusing only on the treatment of chronic prostatitis, chronic pelvic pain syndrome, and thank you for the opportunity to present. Can you see my screen? Can you see my screen, Prof? Is my
Yes, we can see your screen.
Thank you. Warm welcome from Durban. So we'll be focusing on the category 3 chronic pelvic pain syndrome, which is divided into inflammatory and non-inflammatory, as just discussed, and there's no real clinical significance between the two. Chronic prostatitis symptoms for 3 months of the last 6 months, and by definition, any infection, malignancy, radiation, chemotherapy, strictures, neurologic disease of the bladder has been excluded. And inflammatory, so that's your category 3B, is diagnosed by white cell count, increased white cells in your express prostatic secretion, your voided bladder 3, which is the first 10 mils after your prostatic secretion, or in seminal plasma. So treatment, from the EAU, there's a weak recommendation, but it's still a recommendation that you must offer a multimodal and phenotypically directed treatment for prostate pain syndrome. So when you approach this patient, you should always approach them with a biopsychosocial model, treat the patient and not only the disease, to remember that monotherapy don't work and therefore treat them multimodal, and first to start with conservative treatment and then progress to more invasive treatments. And then always important to refer to other specialties. So the U-point snowflake theory, or the phenotypical approach, was just discussed. So treat the patient holistically, look for specific symptoms that can be treated. We are obviously the urologist, they're on top of the food chain, and then to refer appropriately, exclude the most other common diseases which involve the pelvis. So you think about your GI system, you think about gynae pathology, and then to treat appropriately. So it's important to empower the patient, to get the patient involved, get the patient actively involved, give the patient the ability to self-manage, for them to make decisions in their treatment plan, and to tailor-make the plan to the patient specifically, as every patient will have different concerns and different outcomes. And then to refer the patient to reliable sources of information, which is readily available on the internet. But I think the key there is that it must actually be reliable information, as the patient can easily be flooded or even be concerned by irrelevant and unnecessary information. So part of your treatment will unfortunately be that this patient will need to be followed up, and it's a strong recommendation that you use a validated symptom and quality of life scoring instrument. Displaying here from the Campbells is the genitourinary pain index, which is very similar to your chronic prostatitis symptom index. The only difference is that there's added bladder questions. So your main 3 domains is your pain, then your voiding symptoms, which is mostly obstructive, or voiding symptoms, and the third is your quality of life. So this is important, firstly, for diagnosis, but then also for follow-up, to see in which domains the patient improve and which domains treatment must be focused further. So yeah, this is very similar even to your international prostate symptom score, but there's just a stronger focus on your quality of life and more on pain symptoms. So to start with conservative treatment that every patient should be treated for, to treat the patient about pain or pain education, to inform them about the causes, the potential causes, the information that you have, the information that you don't have, and this will relieve the anxiety of the patient. Subsequent stress reduction, I found that 86% of patients do improve only with stress reduction. This can be facilitated firstly by you as urologist, and then also by referral to a psychologist or a psychiatrist, or online programs, which is something that the future will hold. Unfortunately, there's not, what I could find is that there's not really at the moment, but in the future there will be, should be a good online programs for stress reduction. And there's two parts of this. First, stress reduction will lead to decrease in pain, and then also to focus on the adjustment to pain. And this is a strong recommendation from the EAU. Then the S of the U points to treat the sexual dysfunction, and then also to refer the patient to relevant counselors, as this can be a primary cause of and contributing factor to chronic prostatitis, and also a secondary or a consequence of having chronic prostatitis. And examples of what can be done is to explain to the patient alternative to sexual intercourse and what other methods they can pleasure themselves with, and for example different positions that they can attempt that will be less painful during sexual intercourse. So now to oral treatment. By definition, UTI is excluded as a cause of your category 3 prostatitis. Meta-analysis have shown that antibiotics are not effective. Most studies have used fluoroquinolones. The reason for this is that it's got good intraprostatic penetration, as your capillary beds of your prostate lack active transport for the antibiotics. And fluoroquinolones are unique that they contains positive and negative charge groups. They accumulate in the infective alkaline prostatic fluid, and they're also lipid soluble. One theory why there might be improvement in fluoroquinolones is that they contain anti-inflammatory properties. Studies have shown that there is a larger benefit in those with shorter duration of symptoms, and that's why the EAU there at the bottom advised to use antimicrobial therapy in those with symptoms for less than a year, and that it should be used for a minimum period of 6 weeks. The best treatment combo currently that has shown the biggest effect on chronic prostatitis is a combination of antibiotic, which is usually a fluoroquinolone, and an alpha blocker. And in keeping with antibiotic stewardship, we should not give repeated courses without positive culture to direct the treatment. Alpha blockers on its own, unfortunately, it's got debatable benefit, although the EAU does recommend it also to give patients that have symptoms of less than 1 year. Anti-inflammatories, as the term prostatitis implies inflammation, but there's different statistics on this. But only 1/3 has inflammation. Biopsy, as Dr. Vertella said, some specimens of postmortem said up to 70% of people do have inflammation. But it seems that the degree of inflammation is not in keeping with the degree of symptoms. So it doesn't seem to be an isolated cause. In some patients, to treat with anti-inflammatories, there is a benefit. So if available, you can use something like celecoxib, which is a COX-2 inhibitor. Unfortunately, it's not advised to use it as long-term and not use it as monotherapy. So to include this in a multimodal treatment strategy. So just to be of the long-term side effects of NSAIDs, even COXIBs, is that there is an increased cardiovascular risk, and then also your GI symptoms, which is more short-term side effects. Neuropathic agents could be beneficial. The EAU does not advise pregabalin. That's the only one that is specifically stated, but they state that it's not effective. Your 5-alpha reductase inhibitors might have effect in some patients, but it's not advised for general use, so tailor-made this to your specific patient. Phospho 5-deoxysterase inhibitors, like Dalafol. The benefit of using this is that you might treat the patient's LUTS, you might also treat the erectile dysfunction, and potentially also the chronic prostatitis symptoms. Phytotherapy, so herbs or alternative therapy. This pollen extracts does show improvement in small trials. Unfortunately, in meta-analysis, there's not much proof for this to be used. The first phytotherapy I want to mention is the saw palmetto, which is made of the extract of the berries of this palm that grows in the southeast tropical regions of North America. It's a small palm that grows up to 3 meters. And from this article from last month, January 2021, it says at the conclusion actually that saw palmetto was effective and safe and clinical superior to placebo for the treatment of chronic prostatitis. And it has shown that there was actually 73% improvement of symptoms versus the placebo effect of 32%. I think it's just important to watch the space. I think not to necessarily treat your patients just on one placebo multi-center randomized controlled trial, but it's just something that can add value in future. More locally at home, our Honourable Minister, Dr. Mantit Sabalal was a big fan of using the African potato, also known as the South African star grass plant. So in this case, it's got a big root or potato that is the source of the treatment. This plant is native to Southern Africa. Unfortunately, it does show uncertain benefits, so it's currently not advised. Then, if the patient has bladder-specific symptoms, to treat the patient bladder-specific. So something that can be done is PPS, pentosone polysulfate, which is speech with hemicellulose that can augment your glycosaminoglycan layer. This is the protective layer in the bladder. But the EAU is only a weak recommendation to give this as a high oral dose. But I think it's worth to give it a try in patients that does have bladder-specific symptoms. As already mentioned, if the patient has specific tenderness of the pelvic floor muscles, you can refer the patient for physical therapy. Physical therapy there's two parts to it. First is to treat your pelvic floor dysfunction or your myofascial dysfunction, and then also to treat pain. So this can either be done by physical therapy, which will be the physical effect of doing the therapy, and then also by pelvic floor retraining, which will train the patient to selectively contract and relax the pelvic muscles. And the thought about this is that it will break the circle of pain, the circle of pain, spasm, pain, and then that leads to spasm again. It does show to have more benefit at specialized centers, which show that obviously specialized centers are better at what they do, but currently it's a weak recommendation by the EAU. Prostate massage also shows weak evidence, and but it can be attempted as part of a multimodal treatment strategy. Then needling, which can be done, myofascial trigger point release that can be done manually, or it can be done with needling, which can either be wet or dry needling. Weak evidence for that. Others is neurocyclical stimulation. This is shown to have reasonable efficacy. The benefit of cyclical neuromodulation is that it can also improve the frequency and urgency additional to the pain. Unfortunately for these patients, required to be inpatient, they require anesthesia for insertion, and there is a notable long-term complication rate of the device. Percutaneous tibial nerve stimulation is a minimal invasive technique, which can be done in an outpatient setting, so something that is obviously less invasive and is something that can be attempted. other conservative measures that has been proven in meta-analysis to have low evidence is diet, but the patient can obviously try this, and the patient can individualize and they can tailor-made it to themselves, but there's no specific diet that does have a different outcome. Aerobic exercise, everybody will advise a healthy lifestyle, but there's poor evidence for this specifically to improve pain. And acupuncture is a strong recommendation by the EAU, but there's not, well, in Campbell's, they, yeah, it doesn't seem that there is a big response. This patients, it can be used for patients who does not respond to medical therapy, or also those who prefer not to take formal oral treatment. Others that got low evidence, but is quite interesting, is local hypothermia, which can be done with transrectal radiofrequency hypothermia. So it's not recommended. Intraprostatic injection of Botox. In small studies, it does show to have some benefit. Electromagnetic stimulation, where this patient sits on a chair and they receive electromagnetic energy for 30 minutes twice weekly. And it does seem to be improvement of pain and IPS in some patients. Extracorporeal shockwave therapy should have short-term improvement of pain, quality of life and avoiding, but doesn't seem to have a long-term effect. Surgical treatment is very limited. In case of bladder pain syndrome, you can filtrate Johanna ulcers. In case of bladder neck atrophy, but only in those with significant symptoms, you can do a bladder neck incision. Please note that this is not for all patients. And then radical prostatectomy or TURP, very important, is not recommended due to the central sensitization. I think if you do understand the pain condition and that patients get allodynia and hyperalgesia, it would make sense that it would not necessarily help to remove the organ. And circumcision has been attempted. In one Chinese study that showed benefit, but in general it shows poor benefit. Thank you.
Meyer, thank you very much for an excellent summary of the management options. I liked your comment that the urologist is the top of the food chain. I think we'll all agree with you on that one. I think the problem that we have here is that we've got so many different options for treatment, and we've got the EUA guidelines, which most of the treatments, in fact, don't have very strong evidence. If you were seeing a patient, what would you recommend? What would be your first line multimodal treatment for the patient?
I think I will have a staggered multimodal approach. So first, to start with less invasive conservative therapy, educate them about the cause of the pain that will lead to stress reduction, and it has been shown that already 86% of patients do improve with that. And then I think you can, being urologist, to exclude other conditions, and then to attempt specific, like maybe an alpha blocker combined with antibiotics, as usually this patient will present in 1 year, and it is actually advised to treat them in the first year by the EAU. And then to follow the patient up thoroughly and have a validated questionnaire to see in which specific domains the patient can further be improved. And I think also to have a positive approach, but to tell the patient that, to give the patient hope, but to tell them that unfortunately there is no miracle cure, but maybe that is not necessarily a lifelong condition.
Thank you very much. I'm going to bring Steve in here, or if anyone else has some things they'd like to comment on. I think just to mention that we've always only ever had ciprofloxacin as a drug that penetrated the prostate, but I've also heard recently that fosfomycin, which has the benefit of only needing to be given 3 times a week or so, once a day dose. So I think that might be an attractive option for the future. And I think in the small print, there's also doxycycline there, because as Lucia mentioned, sometimes chlamydia might be an infective agent. But again, I suspect I'm focusing too much on the infectious causes. Steve, would you like to comment on Meyer's talk?
Thank you, John, and thank you for both speakers. Really excellent, comprehensive reviews. And I must say, I picked up a few things that I could use after all these years. If I could just quickly plug the fact that we're going to be hosting a webinar on chronic pelvic pain on the 20th and 21st of March, to which obviously you're all invited, where we're going to try and unpack all these issues. The essential thing for me is the multimodal approach, and ideally it should be conducted in the form of an MDT, a multidisciplinary team, because of the fact that any one treatment is not going to work, and 2 or 3 treatments won't work. You need the help of the psychologist and the mindfulness person and the physiotherapist and other colleagues, pain specialists, infectious diseases. But we do remain at the top of the feeding chain because we see these folks. And I think it's important that we understand the mechanisms of central sensitization and the fact that it's not the end organ any longer that's the pathology. The pain is actually the pathology, and it's a central neurological and immunological phenomenon, so it seems. And where we struggle in private practice is MDTs are expensive. And how do you set up an MDT and have patients go to different people? Whereas in the state, I think you've got a wonderful opportunity to set up these MDTs, as has been done at UCT for chronic pain. I don't know what happens at KZN, but that's my 2 cents worth. And again, thank you for an excellent overview.
Thank you very much, Steve. It'd be very nice to get that invite. I don't know whether we could perhaps forward it to Hilgard, who could put it out on the SAUA invite list, or that might be a good way to popularize the meeting on the 22nd. Dr. Meyer, if you can just address yourself, there are a few questions there. I don't know if you can click on the chat, then you'll see the questions.
The first one about PSA change in each, I'm not familiar with any difference in PSA between the different categories of prostatitis, Prof.
Okay, and there's a question there about the role of cystoscopy and hydrodistension. Did you come across that as management?
So I did a presentation a couple of months ago on this webinar about bladder pain syndrome. It is advised as one of your more invasive therapies. Most of these patients do require cystoscopy to exclude other lesions or CIS. And if available, you can give local therapy as well, which unfortunately is not available readily in the government sector. And there has been cases where patients actually do say they improve with hydrodistension, but it can also be used as part of the diagnostic role. I can't exactly remember how long for you do distend it, but again, this was not a recommendation for every patient with bladder pain syndrome.
Thank you. And the last question I think that came up there is the duration of antibiotic therapy. How long do the guidelines recommend?
So they say EAUs is a minimum of 6 weeks. I know with chronic, or in the case of acute bacterial pancreatitis, a patient with abscess or patient that present with shock, you obviously acutely culture the patient. Although blood cultures usually have a similar result of urinary cultures, and you'll treat the patient in that case with a carbapenem or something with amikacin. Then if the patient is fever-free, and you will then go over to something like fluoroquinolone, ciproflox, or levofloxacin for at least 2 weeks. And the thought behind this is that it will actually decrease the patient from going to category 2, which is chronic bacterial, or category 3, which is chronic pelvic pain syndrome. But in terms of chronic bacterial prostatitis, so category 2, or in bacterial, or category 3, just pelvic pain syndrome, it's advised at least 6 weeks.
Yeah, 6 to 8 weeks, I think, would be what's recommended. I'm just looking to see if there are any last comments. I think there's one more message there. I think that Sydney's probably summarized how we can close. Excellent talk. It's very important to understand the patient's expectations and address accordingly. So I think that kind of sums up the morning. Thank you again to Lucia and Meyer for excellent presentation about this challenging topic, and for Steve Eppel's comments today. I think
Thanks, guys. Thanks for the opportunity.
Thank you, Lucia.
Cheers,
well.
guys.
Have a good Friday, everybody. Cheers.